A person is normally able to remain healthy and resistant to infectious microorganisms because of the existence of certain host defenses. These defenses take various forms, including actual physical barriers such as an intact skin or the ciliated respiratory mucosa, or physiologic defenses such as gastric acid in the stomach and immune factors such as antibodies. When a person's normal host defenses are somewhat compromised, that person becomes susceptible to infection. The microorganisms evade and multiply in the body tissues, and if the infective process overwhelms the body's own defense system, the infection becomes clinically apparent. The patient then usually has manifest some of the following classic signs and symptoms of infection: fever, chills, sweats, redness, pain and swelling, fatigue, weight loss, increased WBC count, and possible the formation of pus. To help the body in its normal defenses to combat an infection, antibiotic therapy is often required. Antibiotics are most effective when their actions are combined with functioning bodily defense mechanisms. Empiric therapy is the administration of antibiotics based on the practitioner's judgment of pathogens most likely to be causing an apparent infection. It involves the presumptive treatment of an infection to avoid treatment delay before specific culture information has been obtained. Definitive therapy is the administration of antibiotics based on known results of culture and sensitivity testing identifying the pathogen causing infection. Antibiotics taken before anticipated exposure to an infectious organism is an effort to prevent the development of infection is prophylactic antibiotic therapy. To optimize antibiotic therapy, the patient should continuously monitor for both therapeutic efficacy and adverse effects. A therapeutic response to antibiotics is one in which there is a decrease in the specific signs and symptoms of infection compared with the baseline findings. Antibiotic therapy is said to be subtherapeutic when the signs and symptoms do not improve. This can result from the use of an incorrect route of drug administration, inadequate drainage of an abscess, poor drug penetration to the infected area, insufficient serum levels of the drug, or bacterial resistance to the drug. Antibiotic therapy is considered toxic when the serum levels of the antibiotic are too high or when the patient has an allergic or other major adverse reaction to the drug. These reactions include rash, itching, hives, fever, chills, joint pain, difficulty breathing, or wheezing. An infection occurring during antimicrobial treatment for another infection resulting from overgrowth of an organism not susceptible to the antibiotic use, or a secondary microbial infection that occurs in addition to an earlier primary infection, often due to weakening of the patient's immune system function by the first infection, is called a superinfection. Antibiotics are classified into many broad categories based on their chemical structure. Some of the more common of these categories are sulfonamides, penicillins, cephalosporins, macrolides, quinolones, aminoglycosides, and tetracyclines. In addition to chemical structure, other characteristics that distinguish one class of drugs from the next include antibacterial spectrum, mechanism of action, potency, toxicity, and pharmacokinetic properties. The most common mechanisms of antibiotic action are listed on this slide. Sulfonamides were one of the first groups of drugs used as antibiotics. Although there are many compounds in the sulfonamide family, only sulfamethazole combined with trimethoprim or Bactrim is used commonly in clinical practice. Sulfonamides do not actually destroy bacteria, but inhibit their growth. For this reason, they are considered bacteriostatic antibiotics. They inhibit the growth of susceptible bacteria by preventing bacterial synthesis of folic acid, a B-complex vitamin that is required for proper synthesis of purines, one of the chemical components of folic acid. Sulfonamides have a broad spectrum of antibacterial activity, including activity against both gram-positive and gram-negative organisms. These antibiotics achieve high concentration in the kidneys, through which they are eliminated. Therefore, they are often prescribed for UTIs. Another specific use for sulfonamides is prophylaxis and treatment of opportunist infections in patients with HIV infection, especially by pneumocystis jirovecii, a common cause of HIV-associated pneumonia. Sulfonamides have become a common treatment for outpatient staphylococcus infections due to the high rate of methicillin-resistant Staph aureus infections. Sulfonamide drugs are a common cause of allergic reactions. For patients taking sulfonamides, a careful assessment for drug allergies to sulfa-type drugs such as sulfonylureas, which is a group of anti-diabetic drugs, and thiazide diuretics is critical to patient safety. RBC counts are usually assessed before beginning sulfonamide therapy because of the possibility of drug-related anemias. Renal function should also be determined because of the potential for drug-related crystalluria, thus the reason to increase fluids to about 3 liters per day if possible. The penicillins are a very large group of chemically related antibiotics that were first derived from a mold, often seen on bread or fruit. The penicillins can be divided into 4 subgroups based on their structure and the spectrum of bacteria that they kill. The mechanism of action of penicillin involves the inhibition of bacterial cell wall synthesis. Once distributed by the patient's bloodstream to infected areas, penicillin molecules slide through bacterial cell walls to get to their site of action. Some penicillins, however, are too large to pass through the openings in the cell walls, and because they cannot get into their site of action, they cannot kill the bacteria. Some bacteria make the openings in their cell walls small so that the penicillin cannot get through to kill them. The penicillin molecules that do gain entry into the bacterium must then find the appropriate binding sites. By binding to these proteins, penicillin molecules interfere with normal cell wall synthesis, causing formation of defective cell walls that are unstable and easily broken down. Bacterial death usually results from lysis of the bacterial cells due to this drug-induced disruption of cell structure. Penicillins are indicated for the prevention and treatment of infections caused by susceptible bacteria. The microorganisms most likely destroyed by penicillins are gram-positive bacteria. Patients who are allergic to penicillins have an increased risk of allergy to cephalosporin antibiotics. The incidence of cross-reactivity between cephalosporins and penicillins is reported to be between 1% and 4%. Patients reporting penicillin allergies should be asked to describe their prior allergic reaction. It is important for the nurse to document the type of reaction. The decision to continue with treatment with a cephalosporin in such cases is often a matter of clinical judgment by the healthcare provider. Based on the severity of reported prior reaction to penicillin drugs, the nature of the infection, the drug susceptibility of the infective organism if known, and the availability and the patient tolerance of other alternative antibiotics. Many drug interactions with penicillins, some have positive effects and others have very harmful effects. Because of the high incidence of hypersensitivity, drug allergies should be determined before initiation of therapy. In addition, the patient should be assessed for a history of asthma, sensitivity to multiple allergens, aspirin allergy, and sensitivity to cephalosporins, because these are associated with a high risk for penicillin allergy. Cephalosporins are structurally and pharmacologically related to penicillins. Like penicillins, cephalosporins are bactericidal and work by interfering with bacterial cell wall synthesis. Cephalosporins can destroy a broad spectrum of bacteria, and this ability is directly related to chemical changes that have been made to their basic cephalosporin structure. Modifications to this chemical structure by pharmaceutical scientists have given rise to 5 generations of cephalosporins. Depending on the generation, these drugs may be active against gram-positive, gram-negative, or anaerobic bacteria. The different drugs of each generation have certain chemical similarities, and thus they kill similar spectra of bacteria. In general, the level of gram-negative coverage increases with each successive generation. Penicillins and cephalosporins are particularly identical in their mechanism of action, drug effects, therapeutic effects, and adverse effects. With cephalosporins, thorough assessment of allergies, including allergy to penicillin, is required because of possible cross-sensitivity. The macrolides are a large group of antibiotics that first became available in the early 1950s with the introduction of erythromycin. Macrolides are considered bacteriostatic. However, in high enough concentrations, they may be bactericidal to some susceptible bacteria. Macrolide antibiotics are bacteriostatic drugs in that they inhibit the protein synthesis of a bacterial cell wall. Macrolides are effective in the treatment of a wide range of infections. These include various infections of the upper and lower respiratory tract, skin, and soft tissue. Macrolides are also somewhat unique among antibiotics in that they are especially effective against several bacterial species that often reproduce inside host cells instead of just in the bloodstream or interstitial spaces. The older macrolide products, primarily erythromycin, have many adverse effects. Most affect the GI tract, although the two newest macrolides, azithromycin and clarithromycin, seem to be associated with a lower incidence of these GI tract complications. With macrolides, assessment of baseline cardiac function because of the risk of exacerbation of heart disease and a thorough assessment of renal and liver function may help to identify effects early in therapy. Tetracyclines are bacteriostatic drugs that inhibit bacterial protein synthesis. Tetracyclines are chemically and pharmacologically similar to one another. The most significant characteristic of these drugs is their ability to bind with metallic ions to form insoluble complexes. Therefore, their co-administration with milk, antacids, or iron salts causes a considerable reduction in oral absorption of the tetracycline. In addition, their strong affinity for calcium usually precludes their use in pediatric patients younger than 8 years of age because it can result in significant tooth discoloration. These drugs should also be avoided in pregnant women and nursing mothers. The drugs do pass into breast milk, and this can be another route of exposure leading to tooth discoloration in nursing children. Tetracyclines have a wide range of activity, and all drugs in this class are effective against essentially the same spectrum of microbes. They inhibit the growth of many gram-negative and gram-positive organisms and even some protozoans. Traditionally used to treat acne in adolescents and adults, they are the drug of choice for the treatment of chlamydia, mycoplasma pneumonia, rickettsia, H. pylori infections associated with peptic ulcer disease, syphilis, and even gonorrhea. Clocycline possesses a unique effect in that it inhibits the action of antidiuretic hormone, which makes it useful in the treatment of the syndrome of inappropriate secretion of antidiuretic hormone, better known as SIADH. All tetracyclines cause similar adverse effects. They can cause discoloration of the permanent teeth and tooth enamel hypoplasia in both fetuses and children, and possible retard fetal skeletal development if taken during pregnancy. Other clinically significant undesirable effects include photosensitivity, alterations of the intestinal and vaginal flora, which can result in diarrhea or vaginal candidiasis, thrombocytopenia, possible coagulation irregularities, and hemolytic anemia, and exacerbation of systemic lupus erythematosus. There are significant drug interactions associated with the use of tetracyclines. When tetracyclines are taken with antacids, antidiarrheal drugs, dairy products, calcium and enteral feedings, or iron preparations, the oral absorption of the tetracycline is reduced. Tetracyclines can potentiate the effects of oral anticoagulants, which necessitates the taking of blood more frequently and adjusting the dose of the anticoagulant. With tetracyclines, culture and sensitivity should be assessed carefully. In patients with pre-existing kidney or liver disease, results of renal and liver function tests are needed. The aminoglycosides are a group of natural and semi-synthetic antibiotics. They are potent antibiotics, which makes aminoglycosides the drug of choice for treatment of particularly virulent infections. Serum levels of these drugs are routinely monitored in patients' blood samples. Dosages are then adjusted to maintain known optimal levels that minimize drug efficacy and minimize the risks of toxicity. The process is known as therapeutic drug monitoring. Aminoglycoside therapy is commonly monitored in the way due to nephrotoxicity and ototoxicity associated with these drugs. When an aminoglycoside is taken, both peak and trough levels are measured. Samples for measurement of peak levels are drawn 30 minutes after infusion, and samples for the trough level are drawn just before the next dose is due. The toxicity with aminoglycosides normally limits their use to treatment of serious gram-negative infections and specific conditions involving gram-positive cocci, in which case gentamicin is usually given with a penicillin. Gram-negative infections commonly treated with aminoglycosides include Pseudomonas and several organisms belonging to the E. coli family. Aminoglycosides are also used for prophylaxis in procedures involving the GI and GU tract because such procedures carry a high risk for enterococcal bacteremia. Aminoglycosides are very potent antibiotics and are capable of potentially serious toxicities, especially to the kidneys, nephrotoxicity, and to the ears, ototoxicity, in which they can affect hearing and balance functions. Duration of drug therapy should be as short as possible based on sound clinical judgment and monitoring the patient's progress. Quinolones are very potent bactericidal, broad-spectrum antibiotics. Quinolone antibiotics destroy bacteria by altering their deoxyribonucleic acid, or DNA. These drugs kill susceptible strains of mostly gram-negative and some gram-positive organisms. Quinolones are excreted primarily by the kidneys, which contain a high percentage of unchanged drug. This characteristic, together with the fact that they have extensive gram-negative coverage, makes them suitable for treating complicated urinary tract infections. They are also commonly used to treat respiratory, skin, GI, bone, and joint infections, and sexually transmitted diseases. Quinolones are capable of causing a variety of adverse effects, the most common listed on this slide. Bacterial overgrowth is another possible complication of quinolone therapy, but this is more commonly associated with long-term use. More worrisome is a cardiac effect that involves prolongation of the QT interval on the ECG. A black box warning is required by the U.S. Food and Drug Administration for all quinolones because of the increased risk on tendinitis and tendon rupture with use of the drug. This effect is most common in elderly patients, patients with renal failure, and those receiving concurrent glucocorticoid therapy, or they're receiving steroids such as prednisone. There are a number of antibiotics that don't fit in any of the other categories. Most have somewhat unique indications or are especially preferred for a particular type of infection. Clindamycin is a semi-synthetic antibiotic. Clindamycin can be either bactericidal or bacteriostatic, depending on the concentration of the drug at the site of infection and on the infecting bacteria. It inhibits protein synthesis in bacteria. It is indicated for the treatment of chronic bone infections, genitourinary tract infections, intra-abdominal infections, anaerobic pneumonia, septicemia caused by streptococci or staphylococci, and serious skin and soft tissue infections. GI tract adverse effects are the most common and include nausea, vomiting, abdominal pain, diarrhea, pseudomembranous colitis, and anorexia. Pseudomembranous colitis, also known as antibiotic-associated colitis, is a necrotizing inflammatory bowel condition that is often associated with antibiotic therapy, especially clindamycin therapy. Clindamycin is also known to have some neuromuscular blocking properties that may enhance the action of neuromuscular drugs used in perioperative and intensive care settings. Zyvox works by inhibiting bacterial protein synthesis. It was originally developed to treat VRE, vancomycin-resistant enterococcus infections. VRE infections are notoriously difficult to treat and often occur as nosocomial or hospital-acquired infections. Linezolid is commonly used to treat hospital-acquired pneumonia, complicated skin and skin structure infections, including cases caused by MRSA, methicillin-resistant Staph aureus. MRSA is a particularly virulent organism. The most commonly reported adverse effects are headache, nausea, diarrhea, and vomiting. It has also been shown to decrease platelet count. Flagyl is an antimicrobial drug. It has especially good activity against anaerobic organisms and is widely used to treat intra-abdominal and gynecologic infections. It works by interfering with microbial DNA synthesis. Adverse effects include dizziness, headache, GI discomfort, nasal congestion, and reversible neutropenia and thrombocytopenia. Drug interactions include acute alcohol intolerance when it is taken with alcoholic beverages. Patients should avoid alcohol for 24 hours before initiation of therapy and for at least 36 hours after the last dose. Macrodentin is indicated primarily for UTIs, especially caused by E. coli. The drug is believed to work by interfering with the activity of enzymes that regulate bacterial carbohydrate metabolism and by also disrupting bacterial cell wall formation. It is indicated in cases of a significant renal function impairment because the drug concentrates in the urine. Adverse effects include GI discomfort, dizziness, headache, skin irritation, possible irreversible peripheral neuropathy, and hepatotoxicity. Vancomycin is a natural bactericidal antibiotic. It destroys bacteria by binding to the bacterial cell wall, producing immediate inhibition of cell wall synthesis and death. A common adverse effect that is bothersome but usually not harmful is known as red man syndrome. This syndrome is characterized by flushing and/or itching of the head, face, neck, and upper trunk area. It is most commonly seen when the drug is infused too rapidly. It can usually be alleviated by slowing the rate of infusion of the dose to at least 1 hour. In general, before administration of any antibiotic, it is crucial to gather data regarding history of symptoms indicative of hypersensitivity or allergic reaction. Further assessment should include determination of the patient's age, weight, baseline vital signs with body temperature, and examination of the results of any laboratory tests that have been ordered, such as liver function studies, kidney function studies, cardiac function studies, culture and sensitivity tests, CBC, platelet, and clotting tests. Intake and output measurements should be noted. Baseline neurologic assessment findings are important to note because of the possibility of central nervous system adverse effects. Bowel sounds and patterns should be assessed because of potential antibiotic-related GI tract adverse effects. Cultural assessment is also important because of the well-documented variations in response among different racial and ethnic groups, as well as patients' use of folk remedies or alternative therapies to try to alleviate infections. Learning preparedness, willingness to learn, and educational levels should be assessed because of the importance of patient education to safe administration of medications. Baseline findings from assessment of the oral mucosa, respiratory tract, GI tract, and genital urinary tract should be noted because of the risk of superinfections in these areas. Superinfections are often evidenced by fever, lethargy, mouth sores, and perineal itching.